composite outcomes are really interesting, and in certain areas they are completely routine. So if you think about a secondary prevention study where somebody has a heart attack or a stroke and you're interested in whether a drug reduces their subsequent risk, you would typically measure whether they have a stroke, whether they have a myocardial infarction, or whether they die from cardiovascular disease more widely. And that's probably valid because, broadly speaking, patients would assign a similar importance to each of those events. Okay, death would perhaps be more important, but broadly speaking, people would view, well, I'd rather not have a heart attack, I'd rather not have a stroke. They're almost equivalent. So combining them, and when the biological mechanism of preventing them should be common, is a valid thing to do, and it makes the trial more efficient. In the context of recovery, though, it's more tricky because you would want the things that make up your composite measure to be meaning roughly the same thing. And when you come to recovery, that's much, much more difficult. But where it can be helpful and where it might be useful statistically goes back to the example I gave before, where you might have somebody who has a score of 3 on the modified Rankin scale, but that could be a very wide range of things. And some form of composite measure where you're saying, okay, this intervention is focused on the upper limb and is designed to improve their function through upper limb recovery. Well, could we also look at an outcome that says, okay, their score is, the modified Rankin score is better, but is it also that their upper limb score is better? So we're measuring an effect of the intervention. So in the context of stroke recovery trials, I think composite measures are difficult and need to be used very carefully, but there might be some circumstances where they're helpful. In prevention, I think it's almost a no-brainer that they're useful.